Hey study buddy, this is your local 4th year med student Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 2 version of the case, where the information is geared towards that exam in particular. Check out the Step 1 version of this case if you're prepping for that instead. Lastly, I'm not a real doctor yet, so all the info and sources are taken from the real doctors and their guidelines listed in the description. All of this advice is for the purpose of education, and none of this should be taken as medical advice. So let's start off with introducing our patient. He's an 82-year-old male with burning while peeing for about 5 days, brought in by his daughter, who says he is now mumbling and not really coherent. Let's get a quick set of vitals. His temperature is 100.9 degrees Fahrenheit, or 38.3 degrees Celsius. His blood pressure is 88/50. His heart rate is 100. His respiratory rate is 20. He's satting 98% on room air. And a little bit more about his history. He's had burning while peeing and also feeling a strong urge to go, but he can still make it to the bathroom without peeing on himself. He's been peeing more and often overnight, but that's been happening for the past couple years. He's had a history of dribbling while peeing, difficulty starting his stream, and feeling like he's not emptying completely. In the urine, he usually doesn't find any blood, but sometimes there's a tinge of pink. There's no discharge from his penis, and he has some pain in his lower belly at times. He's also had fever and chills for about 1 day, according to the daughter, and he doesn't have any nausea or vomiting. He's not currently sexually active. So let's start a little bit with the differential diagnosis. His vitals, with an elevated temperature, a low blood pressure, and slightly elevated heart rate and respiratory rate, make me consider some more emergent and unstable diagnoses, things like sepsis, pyelonephritis. But we need to consider a source outside of the urinary tract as well, even though most of his symptoms are revolving around the urinary tract. Because he's an older person with altered mental status, we should also consider stroke, hemorrhage, and an unintended medication overdose. Non-emergent diagnoses we can consider include UTI. The pain with urination tips me off to a urinary tract infection, and we need to see how far up it goes. If it's just in the bladder, it'd be considered cystitis. If it goes up to the kidneys, it's pyelonephritis. And if there's bacteremia, then we would consider that urosepsis. The classic symptoms for a UTI include his dysuria, his increased frequency, and urgency. Pyelonephritis would be all of the UTI symptoms plus fever and chills and CVA tenderness. And urosepsis would be confirmed after blood cultures are positive for bacteria in the blood. STI urethritis is less likely because he doesn't really have any discharge and he's not sexually active at the moment. The collection of symptoms including peeing multiple times overnight, dribbling, difficulty starting a stream, and incomplete emptying makes me consider some kind of chronic obstruction that needs more force to push past. And a main cause of the obstruction is usually from benign prostatic hypertrophy in an older male, but prostatic carcinoma can also be considered. Prostatitis is also a consideration, and one main risk factor for acute bacterial prostatitis is benign prostatic hyperplasia. Other risk factors for acute bacterial prostatitis include GU infections like epididymitis, or UTIs, high-risk sexual activity, or any kind of prostate manipulation, procedure, or surgery. Acute bacterial prostatitis is usually from E. coli or Pseudomonas eklebsiella, though on exams, lots of chlamydia trachomatis, especially if they're young and sexually active, and more routine bacteria appeared in the older population. For chronic prostatitis, this would be recurring prostatitis symptoms for over 3 months and positive urine cultures with each episode. The physical exam for both of these for step and shelves is usually a really painful prostate on digital rectal exam, kind of like the chandelier sign for cervical motion tenderness, where as soon as you touch it, they jump up high enough to touch a chandelier on the ceiling. And this patient also had altered mental status, and with the vitals, this makes us broaden our differential. For instance, maybe he has infection in the urinary tract and some other etiology, and we don't want to anchor on the obvious. There's lots of mnemonics for altered mental status. AEIOU tips is popular, but I prefer to keep AEIOU with the dialysis indications. So move stupid is another one. The M stands for metabolic, which includes hypercalcemia and hyper or hyponatremia. The O stands for oxygen, like hypoxemia. The V stands for vascular, which includes MIs, bleeds, strokes, or hypertensive encephalopathy. The E stands for endocrine, such as thyroid storm, mixed edema coma, hyper and hypoglycemia, and Addison's disease. The S stands for seizures, most notably in the post-ictal stage. The T stands for trauma, which causes hypovolemia. The U stands for uremia, mostly seen in renal failure or missing dialysis. The P stands for psychiatric, like psychosis, catatonia, or steroid-induced. The I stands for infectious, which would be sepsis. And the D stands for drugs and alcohol, which includes an overdose or anticholinergics for the elderly. So let's get a little bit more about this patient to narrow our differential. He doesn't have any weight loss or night sweats, but he does have some fatigue. He doesn't have any headache, he doesn't have any chest pain or shortness of breath. His main symptoms are just dysuria and increased frequency. His past medical history includes BPH, hyperlipidemia, and hypertension. His social history includes smoking for 20 years, about half a pack a day, but he quit 15 years ago. He doesn't do any alcohol or recreational drugs. In terms of home medications, he is on tamsulosin, lisinopril, and atorvastatin. On physical exam, he's ill-appearing. His pupils are equal and reactive. His heart rate is regular rate and rhythm. His lungs are clear to auscultation bilaterally. His abdomen is soft. There's a suprapubic mass and some pain on palpation. It is non-distended. He has normal bowel sounds, and he does have CVA tenderness. His skin is warm and dry. His extremities have equal pulses, and on neuro exam, he is oriented ×2, which is to person and place. So let's talk a little bit more about the diagnosis. So he definitely has a urinary tract infection, but the question is, how far up does it go? In the categorization of UTIs, we can split them up between uncomplicated and complicated. Uncomplicated means you have to be immunocompetent, have no urologic abnormalities, not be pregnant, and be a woman, which means pretty much only young, non-pregnant females could fall into this category. Treatment for this includes fosfomycin 3 grams once, or Bactrim TMP SMX for 3 days, or nitrofurantoin for 5 days. Complicated UTIs include postmenopausal, pregnant, men, immunocompromised, or any kind of urologic abnormalities. As an outpatient, this would be treated with ciprofloxacin for 7 days, Bactrim or TMP SMX for 14 days, or IV ceftriaxone once. Cystitis in men could be treated with, again, Bactrim, Cipro, or levofloxacin for about 7 to 14 days. Going further up, there's pyelonephritis, and our patient fits this criteria because of his CVA tenderness and fever and chills. For inpatient, there's broad-spec IV antibiotics for sepsis management. We can add extended-spectrum beta-lactamases if multi-drug resistant organisms are suspected. In terms of outpatient pyelonephritis, you could do fluoroquinolones, Bactrim, plus ertapenem once, or a new drug, plazomicin, if multi-drug resistant organisms are suspected. And in both, we adjust to culture sensitivities when they come back. Urosepsis can be considered, and these would be confirmed by blood cultures, which we definitely want to take in this patient because he's febrile and altered. And in terms of sepsis, there's a lot of categorization involved. SIRS criteria, which is the older criteria used for patients not in the ICU setting, they only require 2 of the following: a temperature above 38 degrees Celsius or below 36, which our patient qualifies for, a heart rate above 90, which our patient also qualifies for, respiratory rate above 20, a white blood cell count above 12,000 or under 4,000, or more than 10% are bands, which are immature white blood cells. The newer classification is the Q-SOFA, which also requires at least 2 of the following: a systolic blood pressure less than 100, which our patient qualifies for, a respiratory rate above 22, and altered mental status. And the Q-SOFA was created partially because SIRS criteria was kind of too broadly used in the emergency department. Pretty much everyone and their mom kind of fit 2 of the 4 criteria in SIRS. And then we would be getting blood cultures on everyone, and everybody would be considered septic, and that casts too wide of a net. Sepsis requires either SIRS or SOFA to be fulfilled, plus a source of infection. And for him, we do have a source of infection. He has a reason to have chronic UTIs, and he definitely has symptoms for a UTI. For severe sepsis, this would be all of the above plus end organ damage. And this can be defined as a lactate of above 4, creatinine above 2, or less than 0.5 milliliters per kilogram per hour of urine output, which will be considered oliguric, a bilirubin above 2, platelet count of less than 10,000, INR above 1.5, or PTT above 60. And all of these are looking at organ function. A lactate is looking at whether tissues and organs are being adequately perfused, and if they have enough oxygen for aerobic respiration. The creatinine and urine output is looking at the kidneys, the bilirubin and the platelets. The bilirubin, platelets, INR, and coags are looking at liver. And treating sepsis includes lots of fluids, and we'll talk about our initial interventions in a second. But to categorize the final stage of septic shock is when the blood pressure is not responsive to fluids. So for our patient, we require some initial interventions because from his vitals, he's not very stable. He definitely fits the criteria for sepsis, so we would definitely want to start him on some resuscitative fluids. We can use isotonic fluids such as lactate ringers or normal saline, and our goal is 30 cc's per kilogram. And after this, our patient's blood pressure increases to 110/90, which is still a little soft or a little bit on the low side, but it's a lot better than it was before. And if it didn't respond, we would be considering vasopressors like norepinephrine and an ICU transfer, because when a patient is on vasopressors, they need to be constantly monitored for their blood pressure. In the treatment of sepsis, we also want antibiotics within 1 hour, and these would include broad-spectrum IV antibiotics. We can choose a couple of different options. There's piperacillin, tazobactam, or Zosyn for Pseudomonas coverage, and vancomycin for Staph aureus and MRSA coverage. We can also use cefepime instead of Zosyn for Pseudomonas coverage. And no one will fault you for going this broad, but we also want to consider not creating multi-drug resistant organisms when we can. Otherwise, infectious disease will probably find out where you live and knock down your door. So with a UTI as a strong basis, you could switch Pseudomonas coverage for ceftriaxone. If a patient doesn't have a history of UTIs or suspected multi-drug resistant organisms, such as they live in a place with a lot of other people, like a nursing home. But we can also wait until the sensitivities come back from the urine culture. And lastly, for sepsis, we need source control. And with his suprapubic mass, we're concerned that he's retaining urine and that's causing some stasis and bacteria inoculation. So we definitely want to fully draining the urine. And lastly, we want blood cultures and urine culture, like I said before, and we can use the cultures and sensitivities to guide our antibiotic management. If he had a history of previous UTI infections, we could also use that to look at the most likely bacteria that he's colonized with and treat accordingly. So let's take a look at the labs that we ordered on him. On anybody with ultramental status, we definitely want an AccuCheck, which is a point-of-care glucose. It's really easy and quick to do. You do it at bedside and you get the result in like 2 seconds. His was 90, which is normal. So we know that this altered mental status is not from hypoglycemia, which is an easy fix and does not require any of these antibiotics. We definitely want a CBC because we're concerned about an infection. His white blood cell count is 15,000 and platelets are 300,000. We want to look at CMP because one of the criteria for end organ damage is looking at the kidneys, and a CMP can look at BUN, creatinine, and also some liver enzymes. His BUN is 34, and his creatinine is 1.5, which are high and indicate a pre-renal AKI. Another thing we want to look at for creatinine is what is their baseline. For instance, if he had a history of renal failure and his creatinine was normally about 1.4, then this would be an elevated creatinine, but not from his baseline, so his kidneys aren't that worse off. We also definitely want to lactate, and in his case, it's 5, which is high. This is likely from his hypotension not allowing adequate perfusion to his organs. Other studies we want are urinalysis, and for him, he has dark yellow/cloudy urine. His pH is 6.5, glucose is negative, 1+ protein, many bacteria, and 3+ leukocyte esterases, which is definitely indicative of an infection. The urine microscopy gets us a little bit more detail. It is a nitrite positive, it has less than 5 epithelial cells, so we know it's not contaminated. He also has a specific gravity of 1.020 or 1020, which is a little bit more concentrated than normal, which is about 1010. His urine culture is currently pending, and if we were worried that his ultramental status were due to some kind of accidental or intentional overdose, we could get a urine toxicity, but in this case, he doesn't have any warning signs and the urine tox screen is negative. And because he also has fevers and chills, we want to get a blood culture during his episode of being febrile and having chills. This is the best timing for bacteria to grow in the culture. In terms of imaging, what we can do really quick by bedside is look at a bladder ultrasound. This shows 350 milliliters in the bladder and no hydronephrosis. So at least we know we don't need to drain the kidney, but we do have some fluid in the bladder, and I'm concerned that this is where our source of infection is. We can also get a CT head because he's an older person with altered mental status. We would just be looking for a stroke or hemorrhage. And in this case, there's no bleed. And this is our first case with an actual procedure. And in third year and fourth year rotations, you're definitely going to be expected to work on and eventually be competent at simple bedside procedures such as inserting Foley. So let's go over the steps. The first thing you want to do is get set up with your Foley kit opened and make sure you have all of your to be sterile things ready so that when your hands become sterile, you don't have to touch anything that's unsterile that'll make you start over again. After you give the genitalia a wipe with the non-sterile wipe and non-sterile gloves, you'd want to start the sterile part of the kit. Next, you want to get your catheter all set up. Once you lose a sterile hand by exposing the urethral orifice, you only need one hand to finish inserting the Foley. So you're going to lubricate the tip of the catheter. I like to pull the plunger off and put the tip of the catheter in the lubricant syringe. You're also going to drape the field, and I like to clip the saline syringe onto the balloon port first as well. Then you're going to lose one sterile hand by exposing the urethral orifice and using sterile gloves and cleaning either the glands of the penis in a circular motion out from the urethral orifice or an anterior-posterior motion for a female. And all of this is done with iodine swabs. Next, you want to insert the catheter and make sure that you see the flash of urine. For males, you want to hub it, which means insert the catheter all the way until you can't anymore, past the point of the urine flash. For females, it's okay to just inflate the balloon at the site of the urine flash. And this is because male urethras are much longer and you don't want to accidentally inflate the balloon while the tip of the catheter is in the prostate, and then you would cause them exquisite amount of pain and you inflated the urethra instead of inside the bladder. So to inflate the balloon, you syringe about 10 cc's of saline from your syringe into the balloon port and pull it gently to let it rest at the bladder neck. And then you're done. In terms of imaging, after the CT abdomen, we are also concerned about pyelonephritis, and that is a diagnosis made on CT. So our patient had no hydronephrosis or bladder distension anymore seen on CT after the Foley drained the bladder. It also showed an enlarged prostate and no perinephric abscess. The perinephric abscess is a concern when people are treated for pyelonephritis and they don't get better with antibiotics. Then we're considering sometimes this infection is walled off somewhere inside the body that can't be penetrated by antibiotics, and that would be why they aren't improving on the antibiotics. And lastly, consults could include infectious disease for antibiotic regimen if it gets a little complicated with multi-drug resistant organisms. So, our summary statement: he is an 82-year-old male with a history of BPH, presenting with dysuria for 5 days and confusion for 1 day due to severe sepsis from pyelonephritis. Our plan is to admit to medicine. He is in altered mental status, he's also elderly, his vitals are kind of unstable, we don't want him to go home. Indications to keep in mind for hospitalization in patients with acute pyelonephritis: absolute indications would be a concurrent urinary tract obstruction, failure of outpatient therapy, pregnancy, sepsis, or unstable coexisting medical conditions. And in this case, he has sepsis. Relative indications would be poor social support or frailty, high risk of infection with multi-drug resistant organisms, severe refractory pain, or significant comorbidities or immunosuppression. And all of this is from the American Academy of Family Physicians. So his first major problem is that he has severe sepsis. It wouldn't be septic shock because he is responsive to fluids, but this is likely due to pyelonephritis. We currently have him on fluids of lactated ringers at 30 cc's per kilogram. He also has antibiotics, which if we consult ID, they can follow. But with no other risk factors for multi-drug resistance, we can scale down to ceftriaxone or ciprofloxacin if we want to, and then follow up with the cultures and sensitivities once the urine cultures and blood cultures come back. We have source control with the Foley, and we are also going to trend the lactate until it's normalized to make sure we're getting better. He has confusion, likely due to sepsis, and we are going to monitor this as the sepsis is treated and resolves, but we want to keep him NPO until his mental status improves because I'm concerned that he can't protect his airway and swallow correctly, and so we don't want him to choke or aspirate. And in the evaluation of getting him back to a liquid or regular diet, we can also have him do a swallow study, or nurses are also capable of administering a Yale swallow study. He also has an AKI on his BMP. This is likely prerenal due to his BUN to creatinine ratio of over 20. And the next test for this would be urine electrolytes for a FeNA expected to be less than 1% if it's prerenal. We also have administered fluids and his blood pressure is improving, so this AKI should resolve with the hypotension resolving as well. But in the meantime, we also want to avoid nephrotoxic drugs like NSAIDs. For his BPH, which is a chronic condition, we want to hold tamsulosin because it can result in some lower blood pressures, and we can restart this on his discharge. Same with his chronic condition of hypertension, we want to hold lisinopril due to his low BPH and restart on discharge. His hyperlipidemia, we can restart atorvastatin as he is orally able to take medications, but I'm in no rush to restart this. And lastly, our section of curiosities and conundrums. So this episode's rabbit hole is about Foleys. And the start of this episode came from the idea of covering different types of Foleys used in the hospital, but then I covered some more unhinged history of the catheter, so let's dive in. The earliest record is in 1500 BC, ancient Egypt, where urinary retention, mainly in males, were treated by bronze tubes, reeds, straws, and curled up palm leaves, which sounds absolutely frightening. Throughout history, there's a whole toy box of things stuck up the urethra. There are Chinese records in the 1100s where hollow leaves of onion were inserted as well. Finally, we got a little bit more civilized, I suppose. In 1564, Ambroise Paré first invented silver catheters with a curve to make insertion easier. And in 1836, Louise Auguste Mercier invented the coude catheter. And coude means bend or elbow in French. And now they're used for people with prostate enlargements with the curve pointing anteriorly to make insertion easier past the big prostate. The modern Foley catheter was made in 1929 by Dr. Frederick Foley, where he included a balloon at the end. And this was made for post-prostatectomy hemostasis. But now we use it for a whole bunch of things. So a Foley catheter has a tip with a hole in the end for drainage of urine and a balloon to keep it in the bladder. Then the end has either 2 or 3 outputs. One for the balloon inflation, one for the Foley bag or just out to the world, and the third possible output is for adding saline that will irrigate the bladder after a urologic procedure to clear debris or blood so it doesn't clot. That's called continuous or intermittent bladder irrigation. We can also put medication in there for bladder cancer like chemo. Also, catheters are sized by their diameter in millimeters or French units. One French unit is 1/3 of a millimeter. So if you take the millimeters and multiply it by 3, that is your French unit. I don't know why we make communication so difficult in healthcare. And when we take Foleys out, we watch the patient during a trial to void. And this means generally in 6 hours, we need the patient to pee on their own. And if they can't, we would bladder scan them to see if they're making urine, and if they're retaining again, the Foley has to go back in, or they have the straight cath, or we need to figure something out. But the longer the Foley stays in, the more likely we're going to have an infection because foreign bodies are always the nidus of infection. So patients who have issues voiding over a long term due to neurologic issues like multiple sclerosis or spinal cord injuries, we can do intermittent catheterization. The patient needs to do this by themselves reliably, But essentially, they stick a straight plastic straw into their urethra and use that to pee every time. Unfortunately, if something happens with insurance or pharmacy stock and they've run out, they can still get infections by reusing the same one, because otherwise, how would they pee? Also, a complication to long-term use of Foley catheters is urethral erosion. I actually saw several of these, and if it's early, it kind of starts as like a fresh ulcer on the bottom side of the glans penis, and then it could progress until there's just no flesh on the other side of the penis. It almost looks like a mistake, like the hole of the urethra is just a little too big than you remember, but in an unsettling way. And this is why suprapubic catheters exist. This is where we put them on a long-term catheter in the bladder that goes out the abdominal wall above the pelvis. This won't put traction on the urethra like the Foley catheter does, that causes the urethral erosions. And lastly, I just learned about this, but there's a temperature-sensitive Foley. And this is particularly useful for monitoring body temperature in the OR. Normally, anesthesia can monitor body temperature through inserting a probe into the esophagus, but when you're doing cases that involve the esophagus, like an esophagectomy, you need a different way to monitor their temperature. And this is where a temperature-sensitive Foley would come in handy. So, to recap our teaching points, our UTIs are categorized as uncomplicated or complicated. Uncomplicated are basically young, non-pregnant women. Complicated is basically everyone else. In sepsis classifications, you can either use SIRS or QSOFA. QSOFA is the newer one and more useful for infection outside of the ICU, but you also see SIRS being taught or talked about a lot as well. Sepsis is either one of those being qualified plus a source of infection. Severe sepsis is all of that plus end organ damage, usually with a laxate or kidney numbers like amount of urine or high creatinine, or you can look at liver like INR and platelets. And lastly, it would be septic shock when the fluids that you give them doesn't increase their blood pressure and you're thinking about starting them on vasopressors like norepi and considering a transfer to the ICU. Our sepsis workup includes fluids, 30 cc's per kilogram, broad-spectrum antibiotics, blood cultures, urine cultures, all of the cultures, to find the bacteria, and source control. And our procedure that we covered today was a Foley. So that wraps up the case for now. Feel free to check out our other cases on the podcast in the meantime. Drop a comment to let us know how we're doing, and next time you pass by your friend who's always a tad bit too stressed, remind them to be grateful that Foley practice models exist, and we are no longer in the age of shoving anything with a lumen up the urethra. Alright, see you in the next one.